Okay, and we are also live on Facebook, so good morning to everybody who's watching us there. If you've got a question you want to ask, we can take questions from there as well. Just pop it in the comments box and one of my colleagues will ping it over to me via the magic of the internet. I think we might as well make a start there. We are expecting another couple of panelists, but they'll join us throughout the webinar. So if you've got a question that's relevant to them, I will make sure I hold off and ask it to the appropriate person. So could we have the slide down now, please, if possible, and we will begin. So welcome once again, everybody. And just a reminder to ask questions, it's the chat button at the bottom of your screen. We won't be allowing anybody to speak or share the video or anything like that, just to help us cope with the numbers of people involved. Welcome to our panelists as well. So just to introduce myself, I'm Charlotte. I'm the Patient Advocacy Manager here at Leukaemia Care, and I will be chairing today's meeting, so I'll be fielding the questions and discussing with the rest of our panelists. So today we are joined by a number of other people. So we've got Kate. Kate, do you want to just quickly say who you are?
Yeah, hi, I'm Kate. I'm an APL patient and I'm also a trustee of Leukaemia Care.
Cool, thank you very much. And we've also got Dr. Steve Knapper. Steve?
Yeah, hi, good morning everyone. I'm Steve Knapper. I'm a consultant haematologist based at the University Hospital of Wales in Cardiff, where I look after patients with acute leukemia, amongst a few other haematological conditions. So very happy to join you all this morning. Hopefully I can help.
Thank you for your time, Steve. And we've also got Angie, although she was having some technical difficulties, so we'll see if she can hear us. Angie, are you there? If you are, you're on mute at the moment. No? Okay, that's not a problem. We'll come back to Angie in a moment. We're also hoping to be joined by Amit Patel, who is from the Christie, answer some of your more transplant-related questions, although he's been delayed slightly, so we'll see how that goes. That's not a problem. Okay, so just to kick off then, if we could come back to Kate. Kate, could you just tell everybody listening, sort of as an APL patient, a bit about your story and your experience with today's topic, if possible?
Yeah, so like I said, my name's Kate and I'm an APL patient. So I was actually diagnosed in September 2016, had extensive chemotherapy. Everything seemed to be going well until the third round of chemo, and the APL came back in my cerebral spinal fluid. So I then had intrathecal chemo, arsenic treatment, and eventually an auto transplant, stem cell transplant. Thankfully for me, I'm in remission and have been since 2017, which is great. And I'm here today to talk about sort of the challenges I've experienced post-treatment and how I've coped with it, and various challenges that have shown in that time, really. So for me, the main thing sort of post-treatment was just trying to get back to some sort of normality, which I found extremely difficult, actually. I think you go through something very traumatic and the treatment itself is traumatic, but having to adjust to a life post that is very tricky. And I think a lot of people around you think you're cured and that you're fine again, but actually I found for me it was more the mental side of things that were harder to cope with than the physical, and that involved things like going back to work, trying to sort of deal with the fatigue and challenges around that, how your body has changed. I found that before I was diagnosed I was relatively fit. Afterwards my body felt like it was in bits, basically. So again, that was difficult to kind of get my head around. I'm a young person and I felt like my body had changed a lot. The biggest thing for me was the fatigue issues surrounding treatment. For me, unfortunately, it made me infertile. So having to deal with that when you're in your early 30s or just turned 30 was really tricky. And to be honest, I still struggle with that today. And I'm 3 years out of being in remission. So that was very difficult. And I found actually trying to access treatment for that extremely tricky and hard to come by. Things like HRT, and just knowing the right person to speak to about it. I found, I don't know if other people found this, but I found I kind of got passed from pillar to post, it's not my department. I'll pass you on to someone else. So it was a few months before I had the HRT. So actually dealing with the symptoms of rapid onset menopause was tricky and upsetting. And a lot of the symptoms that I had, I didn't realise could actually be helped really, by just taking a small HRT pill. So for me, that was challenging. And I think I would just like to say to people who are dealing with that sort of issue, keep asking for help and search for on different sources for information and help. Ask your GP, ask your haematology team, and see if they can put you in contact with someone who knows how to help you. Other things, challenges that I found sort of post-treatment was trying to get help from a late side effects team. So for me, because my treatment was split between 2 hospitals, the QE in Birmingham and Worcester Hospital, I felt that it was hard to get a team. Everyone talked about this late side effects team that was going to be there to help me for the rest of my life, but it felt very difficult to get an appointment with them. And I realised that just massively oversubscribed, basically. So I found that tricky. And eventually, when I did get an appointment sort of a year later, I think they were fab, brilliant. And it was the endocrine team at the QE that have been fantastic. It's just very hard to get appointments with them. And I'm not the only patient who I've had that feedback from. So I imagine there's quite a few people out there who struggle with that. I should be going once a year to that team. Obviously with COVID, that's kind of stopped. Which I think is a lot of people at the moment. And I'm sure that there's lots of people out there who are struggling to get seen. So issues I've had health-wise post-transplant, skin issues, dealing with the sort of sore skin or itchy skin, mainly from radiotherapy, like total body irradiation, the chemo. Also things like osteopenia. So I've had bone pain, joint pain. I've had bone density scans, which have shown that there is a thinning of the bones there. So that's an issue for me. And obviously there's the risk of things like cataract and thyroid issues, which all have to be checked, on a yearly basis, really, for me. So that's mine in a nutshell. I know I've been very brief and it just seems to be negative, but I'm just trying to focus on the major things that have affected me since my transplant and treatment, basically. And obviously I'll try and help in the questions and Q&A and things like that. So yeah.
Perfect. Thanks, Kate. I think you're getting a really nice overview there of some of issues that I'm sure a lot of people listening can relate to. And we'll certainly come back to some of those. I've made some notes to come back to. Next, we go to Steve. Steve, could you, Kate's obviously mentioned quite a lot of the physical effects already there, but could you just say a bit about, from a clinical perspective, what side effects and long-term effects you perhaps are anticipating with some acute leukemia treatments and what people should be looking out for, really?
Sure. So I think just to emphasize that when we treat patients with acute myeloid leukemia, there are very much different approaches we take in different settings. And I think what we're mainly concentrating on in this meeting is really where we've used an intensive, usually chemotherapy-based approach to offer a reasonably good chance of getting patients into a remission and then potentially offering the prospect of long-term cure. So that's really the side of it I'm coming from here. There are a significant proportion of patients, and I'm not sure if there are any people on the call that this applies to, that we treat using sort of less intensive, non-intensive strategies where the aims are sometimes a little bit different. But some of the effects of those treatments do share quite a lot of characteristics with what we're doing with intensive treatment as well. So I'd be very happy to answer any questions about that as well. So I think the first thing I'd emphasize is that I think everyone is very much different. And one of the things we see in our job is that no two patients who are going through acute myeloid leukemia treatment are completely alike, but there are a lot of shared experiences. And I think one thing I'm sure we'll come back to over the course of this webinar is that your experiences are really important, and being able to share experiences with other patients is really important and can provide a lot of support as time goes on. I tend to treat patients with intensive treatment, but at the point where some of them get referred for allogeneic stem cell transplant or bone marrow transplant, I tend to then pass them on to the follow-up of colleagues that are more dedicated to allogeneic bone marrow transplants. So I think some of the long-term complications of AML treatment are specifically related to this, so the slightly more predictable long-term side effects related to transplant. And we can talk about those in the non-transplant setting. We would generally follow up patients in our outpatient clinic for at least 5 years following completion of treatment. And in many cases, when we get to the 5-year point, we ask patients what they prefer to do, where some really want to be discharged and have a feel of sort of finishing the whole process at that point. Other people do continue to derive quite a lot of benefit, or certainly say they do to me, from keeping the contact and coming back, even if it's at only long intervals, such as every 6 months or a year. Some of the effects we see from intensive chemotherapy are very predictable and largely temporary, and this is effect on things like hair and skin and nails and the immune system, which tend to be, again, this is not talking about the transplant setting, but more the intensive chemotherapy setting, things that tend to recover within a certain number of months, although that certain number of months is variable, of finishing treatment. A few of the side effects, and this is, I think, probably something that is a little bit more difficult to get heads around and potentially sort of cope with having in the background in the long term, are things that are slightly more idiosyncratic, such as potentially cardiac complications of chemotherapy, and sometimes the risk of second cancers further down the line, including second leukemias. So some of the, I think the thing with long-term effects is some are predictable, some happen within a certain time window of treatment, but some are slightly more idiosyncratic and can happen further down the line. So I'd be very happy to discuss any of those things this morning. I think that the other thing to emphasize is as doctors, we tend to be in a bit of a comfort zone. Maybe I'm talking just about myself, but I think it is a general feature when we're coping with kind of physical effects of treatment and sort of physical diseases and complications that can happen following treatment. But then I think sometimes we're slightly less prepared for some of the more sort of mental, psychological aspects, and it's really important that doctors do look into this as well, but it's really important that the multidisciplinary team and all the support networks, including Leukaemia Care, have a really big role to play in that setting. And I think the final thing before I sort of hand you back to Charlotte is that I think the COVID pandemic has caused some particular challenges with follow-up as well, because I think particularly the patients who are further on from treatment and are in the sort of window 1, 2, 3 years out of treatment, where we've previously seen them physically on a fairly regular basis, face-to-face in clinic, which lends itself to discussions. Once you've looked at the blood count and reassured that everything is nice and stable, it does lend itself to a more of an open discussion in clinic. But I think doing a lot of these longer term follow-up clinics over the telephone is probably more challenging and probably lends itself less to discussing some of these wider issues. So I think it's really important when you have these longer term clinic appointments, just try to make sure you flag up early on in those discussions that there are things you want to discuss, and have a note of a few of those things next to you when you're having the call, so that these things don't just get kind of brushed under the carpet in a quick, your blood count's okay, before the doctor moves on to the next patient, because it is really important we continue to offer support for these issues.
Thank you, Steve. That's a really important point, and I think it came up a little bit in Kate's as well, is to advocate for yourself, and to, if you've got an issue, to make sure you tell someone and get the ball rolling, because you can't get support unless you ask for help, which I know is challenging in and of itself. I guess that kind of moves us nicely on to Angie. Angie, hi, thank you for joining us. I hope you can hear us, and I hope we can hear you in a moment. I wondered if you could just say a little bit, if there's anything you wanted to add on the clinical side from what Steve said there, but also a little bit more about the emotional effects and how you, perhaps as a nurse, support patients experiencing long-term side effects or late effects of treatment, and what sort of mental support you can provide them.
Can everyone hear me then?
We can sort of, is it possible you can come any closer?
Yeah, that's fine. So yeah, I'm Angela. I work at NHS like Steve. I'm a haematology nurse by background, and obviously as a nurse advisor for Leukaemia Care. So what I would say about most of the the patients that I deal with, that on telephone or face to face when we're working, in our NHS role, it is around sort of emotional issues, and yes, as Steve said, the face to face appointments do give us a good opportunity to be able to have a little chat with a patient, perhaps before they go and see Steve, the doctors, so that we've perhaps got a little bit of a feel for how things have been for patients, during that time away from us. I think what I get calls and some of the conversations that I have perhaps in the NHS and on the leukemia telephone calls are around, people feeling isolated, as Kate said, about getting back to work. I think, sometimes if we can see that perhaps someone's having treatment, so that's the physical signs of someone having treatment, but actually when the treatment's over, and this is what some of the patients and family members say, is how do they support their family member who's finished treatment? It could be young women that are going to try and get back, they might have young children, and because they've finished treatment, I guess there's an expectation that yes, they can take the children to school, and you've had a transplant, it takes a very long time to get over those effects from high intensity treatment, as we know, but it's about, I suppose, people's perceptions and how much we think we should, it's like, be kind to yourself, do talk to your family and your friends, explain that yes, the treatment's over, but there is that period of having to adjust, and they may not be able to get back to the things that they could do. They might not be able to go and fetch children out of school every day. It's sort of about discussing what you think you can do at the time, and then later on, I guess, like Kate, sometimes patients say about their social networks and may have changed because people have moved on. I guess, especially at the moment, with COVID, there are now as well in some hospitals the support about living well and beyond cancer. And I guess that was in its infancy, but I think they're coming on board now. And again, like Kate said, maybe they're a little bit more accessible to be able to tap into, so that if we're aware that someone is struggling, or we make those referrals to the appropriate teams. Because like Steve said, we try our best to refer, but we need that conversation with the patient or their family to be able to say someone needs a little bit of support or guidance, and pointing in the right direction, so that we can help facilitate that.
Thank you, Angie, for that overview there. That's really helpful. I'm really glad you could join us in the end. So we've got a few questions that were submitted in advance. We'll start with those, but please do keep bringing your messages in. I've seen a few come into the chat, and I'll get to those sort of once we've done the ones that came in advance. So we've got a question from a person with APL who was treated with arsenic, specifically arsenic trioxide, which I believe is a fairly common treatment for APL, and they're telling me that they've now suffer with joint pain. Before I ask the specific question, which is more of a sort of medical question, Kate, I believe you had experience of arsenic. How was that treatment for you? Are you able to say whether any of your long-term effects was due to that treatment in particular, or was that not something that's possible to know?
I think for me, I definitely have joint pain, definitely, which has reared its head more so in the last sort of 8 months than ever. Whether that's down to the arsenic, I'm not sure, because I had chemo, arsenic and intensive radiotherapy, so I don't know.
Yeah.
The main side effect for me with the arsenic was heart issues whilst I was having it, and also massive fatigue. It just knocks you out. So I don't know is the answer to that. Perhaps, could be, yeah.
Yeah, thank you for that. That's helpful. Steve, is joint pain something that's fairly common with intensive chemotherapy and treatment similar to arsenic? Should this person be surprised they have joint pain, I guess is what I'm asking.
Yeah, I think people get bone issues and joint issues for a number of reasons with different types of AML treatment. I mean, arsenic treatment is very, very different to conventional chemotherapy because it's absolutely transformed the way we treat this subgroup of patients with APL now, in that we're able to treat them without, in a lot of cases, Kate was slightly different, without giving intensive chemotherapy at all. So that does come with huge advantages in terms of especially the short-term complications affecting the immune system and all the other things which intensive chemotherapy do. But I think we are all in a bit of a learning process with arsenic, because APL is quite a rare condition on a population basis. So even big sites, and we're a fairly big leukemia treating site in Cardiff, we wouldn't expect to see more than, say, maybe 4 or 5 patients every year with APL. And so we're all getting experience of arsenic and its longer term effects gradually. And I couldn't tell you that I've studied the literature, and I'm not going to give you a sort of off-pat answer about this, I'm afraid, but I have seen 1 or 2 patients with long-term issues following arsenic treatments, such as bone pains and joint issues. I haven't really seen enough of it to be very specific about it or to give you very much meaningful advice, I don't think, other than to say I think we are in the middle of a learning process with arsenic, and I think we'll get more experience of sort of survivorship following arsenic, because I mean the great thing about arsenic is it's so fantastically effective at treating APL that, I mean, the long-term survival rates are kind of getting close to 100% now in people who get over the initial 2 or 3 week period following following diagnosis of APL, where there's risks of bleeding problems and clotting problems. So that the long-term survivorship is really, really good. So it's an excellent treatment, and I think we will get better at knowing about the some of the slightly more unusual long-term effects as time goes on.
What about bone or joint pain or bone issues following other intensive treatments? So maybe the intensive chemotherapy that is used more commonly in AML and ALL, is that a common long-term side effect you see with those treatments as well? And what's the sort of the basis for that? Why does bone and joint pain happen following chemotherapy?
I mean, I'd say I think there's probably 2 main categories of that. We don't see it so much following conventional AML treatment with intensive chemotherapy. That's not to say it never happens, but I'd say the 2 groups of patients that are most susceptible to bony issues are people with acute lymphoblastic leukemia, ALL, who get a lot of high-dose steroid treatment as part of their chemotherapy. Steroids in themselves don't tend to have as much of a role to play in AML, and steroid treatment can sometimes lead to risk of osteoporosis, and also to certain complications, such as particularly a bony complication called avascular necrosis, which affects various bones, but particularly the hips. So it's something that needs to be looked at and can usually be picked up by X-rays and MR scans in people who've got bone pain following particularly ALL treatment. I guess the other setting, as with so many things, is that allogeneic stem cell transplants tend to cause quite a lot of disturbance of people's hormone profiles, and that can lead to a significant risk of osteoporosis as well. So that osteoporosis being reduction in bone density, some of that, as Kate touched on, is related to sort of changes in hormone levels and early menopause type effects as well, that can have a knock-on effect on bone density. So these are the things that tend to get monitored for, particularly in late effects clinics following allogeneic stem cell transplant.
Thank you, that's helpful. Just to ask one follow-up question on that, somebody has asked a question whether existing osteoarthritis, could that have been exacerbated by these intensive treatments? They've had both the transplant and they've had steroids and they've had chemotherapy. So is it always connected to the treatment, or is it a case of you're not always sure of the exact clinical course of some of these things?
I think that last point is extremely true. I mean, I guess it applies to medicine in general, and we like to sort of generalize and put people in pigeonholes, but I think that everything is causally affected by other things. So if you've got a pre-existing bony issue, I guess going through a period where your activities are very different, you're doing different things, you're bedbound for long periods, sometimes that can all sort of contribute. You might lose a lot of muscle bulk if you're bedbound, or you're not exercising as much during chemotherapy, and I guess that can have a knock-on effect on pre-existing bony issues as well. So these things, I mean, they all do tend to be interlinked.
Yeah, okay, that's helpful. And I guess, Angie, just while we're on this last point about bone issues, the two people who submitted questions about joint problems or bone problems both sort of indicate that they're struggling to get support for those issues. And what advice do you have for them in terms of getting further support for these things? Oh, I can't quite hear you again. Still struggling a little bit, sorry.
Yeah.
I caught the yeah, let's see what happens.
So what I would say is that Steve has already said that, we'd have to discuss really that could we put them forward. A lot of patients now everyone advocates exercise. Is that possible? It's on how they are physically, exercise helps as well, but medically so sometimes you can access services or support through your local areas, and I guess it's finding out from your team, having that discussion about the late effects team, and as I say, they're living well and beyond with cancer team, as to whether you can get a referral for some more gentle exercise. Maybe you could be referred to a physiotherapist. So there are sometimes things that we can try and sit down, discuss what would be the best way forward for that person. Can you hear me?
I think we caught most of the last bit. I think with the other panelists unmuted, we couldn't hear you, but now everybody else we can just about hear you. So we'll keep going and we'll see how it goes. I did have a follow-up question for you, Angie, just on something you just said a second ago on late effects. The late effects teams that Kate mentioned and you just mentioned, is that something that's sort of a widely available thing across the NHS?
And Kate has said, it may be that you'd have to ask you locally, but it could be something that someone can tap into. But in some of the DGHs, what they've started to do now is employ teams that are living well and beyond cancer. That is obviously, I know this is for Leukaemia Care, but patients who have had a cancer that are then, it's called about survivorship, and it's sort of giving patients plans and written down details about what to expect, and like Steve said before, and Kate, is what things should we be looking out for, who can I then contact, and what these teams are trying to do is engage with the patients and their families at the beginning of that treatment, so that when they're going through that treatment, they can then you know, follow the progress of that patient. So we're all trying to work together to sort of, you know, be there to support the patients throughout that treatment journey and beyond.
Great, thank you. So the message, I guess, is if it's not called a late effects team in your area, ask what else there is. Yeah.
What I'm saying is utilise your team, because they can help you, point you in the right direction, because we may not have all those services at site, but we can then work with the community and your GP and hopefully get the right referral.
Great, thank you, Angie. And I think we can just about hear you now, so hopefully it will go smoothly from now on. The other question we had in advance, oh, I appear to have lost it. Where's that one gone? Ah, here we go. So there was a question, I guess, for either Steve or Angie. I'll ask both of you to comment, but what sort of research is ongoing in terms of into generally late effects of leukemia treatment? I wonder whether, Angie, you want to start. What do you know about do you know anything about whether people are continuing to look into long-term effects of cancer treatments such as these?
I mean, Steve is obviously one of our leads for the haematology trials, and obviously I work in trials myself, but some of the studies that we're looking at is obviously we follow patients up long term for clinical trials. A lot of our patients have been entered into the haematology clinical trials, and so that could be quality of life questionnaires, so patients are continually helping and supporting, being able to tell us exactly how they feel. So some of those are about quality of life questions, which includes physical and emotional well-being. So I don't know whether Steve wants to sort of add into that, but there are ongoing projects, and some of obviously the research and that we're looking into is again about how can we help with some of the physical side effects that patients have, but again with Steve, I think we've got some like long-term study trial follow-up, so patients with perhaps more chronic leukemias as well are we're following up their progress with as I say, long-term follow-up, so that we can monitor for these longer-term issues.
Thank you. Steve, did you want to comment on anything to do with sort of trials ongoing in this area?
Yeah, I think to be honest, it's been a bit of a neglected area really, because I think we've been very good at doing trials in the AML world over the last few decades, really comparing drug X and drug Y and different modifications to chemotherapy schedules and looking at arsenic trioxide and things like that. But I don't think there's been so many studies historically that have kind of concentrated on some of the kind of non-drug treatment aspects of how we get best outcomes and best return to normality for people who go through AML treatment. I think it is. I don't think we're there yet. I think it is changing though. I mean, in the UK, we've got we kind of run the national trials strategy through a group called the AML Working Group, which I'm a member of, and we have got a kind of supportive care group within that who are designing some quite interesting potential trials at the moment, looking at different aspects, not just of post-treatment activities, but also the other things that happen while people are going through treatment. So what thresholds to use for blood transfusion, different sort of nutritional interventions, different ways to manage fatigue, psychological support and things like that. And it is quite a big, there's quite a big initiative around this, not just in blood cancers, but in cancer in general. And there's been a call by the NIHR, which are one of the big national government supported funding bodies for applications in this line. And so we're planning to put some applications in for that in the next few weeks actually, and hopefully we'll be able to tie in that to the next big national AML trial which is going to be running over the next 4 or 5 years, called AML 20. So I realize that most of you have probably gone through this already and are sort of I'm very pleased that you're at sort of later points of your kind of treatment process. But I think there is going to be a lot more research in these directions going forward.
That's really good to hear. And the last question I wanted to ask on this was to Kate, actually, to ask what you'd like to see more be done about these things. Is there something you'd like to see particular research on from your experience?
Yeah, I mean, we touched on the arsenic treatment being used for APL now. When I was diagnosed in 2016, it was around, but it wasn't available to me. So I think, like we've already said, more kind of research and more use of arsenic is as a gentler kind of treatment for APL in terms of not having to have chemo or things like that would be great from my perspective. But also I think more about, and this is a very personal issue, more about the fertility and preservation of that really around treatment, especially stem cell transplants. You know, that is kind of the final point of preserving fertility, as if you like, when you're going through a transplant. So I would perhaps like more research into that. But yeah, for me, I think it is the arsenic around the APL. Yeah, definitely.
I guess maybe we could talk a little bit more about the fertility side of things at this point. Then I was sort of a follow-up question I had from your introductory talk is how did that affect you at the time, being told that these treatments would potentially have this such long-term impact at a point where obviously you were dealing with the fact you've got a life or death situation essentially? How did you cope with being told about that particular long-term impact?
Not very well. How I coped with it. I think it was the biggest concern that I had from being told you have cancer. Immediately, you know, your mind races and you think of all the things you're going to have to go through. But I think that was the biggest thing for me. And then having relapsed and then having to have further treatment and a transplant, I obviously knew that would, you know, kind of wipe out any chances of that. So I think that was very difficult. And I think there is a distinct lack of psychological support, or at least I found at the time. You're very much, it's clinical, and of course it's an acute leukemia, so you're gravely ill and you have to have treatment straight away on an emergency kind of basis. So I get that, you know, there's very little time to give yourself time to adjust to it or to talk to anyone around the issue. But I think there could be more done to support people psychologically. I'm not saying this has to be done through the NHS. I'm just saying it would be good to have more support in that form, if possible, because I think for me, it was a trauma that I had to deal with and park almost and get through the treatment. And then it's like post-treatment, it's wow, this has happened and now what? Yeah. So yeah, that's how I would see it. And also physically, it takes its toll on you, you know, whether you try and preserve eggs or however you want to go through some sort of fertility preservation treatment, if you can, if it's even an option, is an issue. And I've heard people as well say that they've been through treatment and never knew it was going to affect their fertility. And for me, I always did, and I was always told that. But I think perhaps it should be more discussed when talking about treatment, because I have heard that a lot of people didn't realise that this would affect things. So yeah.
Thank you for sharing that with us. It must be quite a difficult topic for you. Angie, just picking up on the last thing that Kate said there about potentially there are some people who don't know that that's coming or don't get to have that conversation. How do you bring that up in your clinics when you're about to start treatment with someone? How do you bring up the fertility issue, and what support should people be getting? What should they be asking if they haven't had that conversation?
Sometimes things have to be done quite quickly and there are limited resources around. I think sometimes it is there's a time element to get through the diagnosis and to try and get all that information across when patients are really traumatized by having it, you know, as Kate, you know, we turn people's lives upside down. They perhaps, you know, going around their normal life, and they've had a short time of not feeling well, have a blood test, and then obviously things move along quite quickly. So we do try, and I'm sure Steve would, to get that information. I mean, obviously patients are given written and you know, verbal information, but it is very difficult, and I think we do probably struggle to get that information across. It is there, but as Kate said, I think, you know, it is, the focus is around treatment. But I'm hoping that, I guess, with these newer teams on board that are you know, are around the local DGHs. Obviously, I don't work in a regional centre, but again, is across the country that they are employing teams to specifically look at some of the longer term issues. Then I'm hoping that that pathway, or that, you know, that information will be there more readily, and that there will be someone that can sit down and explain and explore the options with patients and their families. Again, I don't know whether Steve would agree with that, or
Steve, did you want to add anything to what Angie said there?
Yeah, I think it's a really it's a really difficult issue, and it's very, very challenging. And I think, again, it's something I don't think there's no sort of universal way that makes it easy to deal with. I think, as Kate touched on, that the treatment that has the most kind of predictably disastrous effect on fertility is really total body irradiation treatment before bone marrow transplant, and often you don't actually know at the start of the kind of treatment journey with a patient with AML whether they're going to need a transplant further down the line or not, and that information only tends to sort of come through as all the genetic results come back and it's clear how they're responding to treatment, and potentially further down the line if they were to relapse following initial period of treatment. So and the other very challenging thing with AML is because it's a acute aggressively presenting condition, the very small window, which is sometimes only a few days at the time of the initial diagnosis, unlike some other types of cancer, it doesn't offer long enough time to actually put anything in place to harvest eggs or remove ovaries or anything like that, which could potentially be considered if the patient was medically fitter, and we were able to delay treatment for the several weeks that it would take to do that. So sometimes I think more could be said at the beginning in terms of the effects of treatment on fertility. I think it's very difficult though when, I mean, people become expert in their condition as time goes on, and they learn more and they have more conversations with doctors and specialist nurses, etc. But at that very beginning of treatment, where everything is completely raw and new, and you don't know what a red cell and a platelet is, and we're sort of giving very general information about the blood and bone marrow and disease and things, it is very difficult to go into a lot of detail about exact percentages of fertility risk when we don't really know at the beginning exactly what parts of the treatment pathway different patients are going to go down. So I think we could do it better, and I think we could probably signpost people to more detailed information specific to different types of treatment, but it is a big challenge.
Yeah, I'm sure it's a difficult conversation for all parties to have at that point. So I'm conscious I took us down a path that away from the questions that I promised to answer that have already been submitted. So let's go back to some of those if I may. And Steve, if I may do sorts of maybe a bit of quick fire ones. There's people who are asking about specific side effects, and I appreciate we can't cover every single one, but I wondered if we could just sort of quick fire try and cover some of those. So one was around peripheral neuropathy. Could you say a bit about what peripheral neuropathy is, and is that common among patients with intensive treatments?
So peripheral neuropathy is where the nerves, particularly in the hands and feet, so the peripheral parts of the nervous system are affected in some way, and it usually manifests itself in a loss of sensation, so numbness, tingling, being unable to do sort of fine tasks like writing and doing up buttons and things like that. So peripheral neuropathy has been associated as a side effect with a number of different drug treatments, and it is associated with a number of different chemotherapy treatments. Again, I think that the commonest chemotherapy drugs that it's associated do tend to be ones that are used more in acute lymphoblastic leukemia, ALL, than in AML. So there's a drug called vincristine, which is particularly associated with peripheral neuropathy, but it can happen as a rarer side effect of a number of other drugs. So it's important that it's, and again, I think arsenic trioxide is another one of these drugs where we do see small numbers of patients reporting these symptoms of getting this peripheral numbness. So I think it's very important that these symptoms are flagged up and we're told about them very soon after patients notice or are concerned about them the first time, because I guess what we want to try to do always is try to objectively work out what's going on and try, if there is a drug that's linked to it, to try to think about alternative drugs and reducing exposure. I mean, the difficulty obviously comes when someone's had a course of chemotherapy, big doses of chemotherapy drugs, we're not necessarily needing to use that agent again, but then they are left with some numbness or neuropathy following that. So yeah, it's another challenging symptom. It's not something we see so much of. Again, it might be something that's seen a little bit more in the aftermath of allogeneic stem cell transplant. Again, low threshold for investigating it. There are various things that can be done, like nerve conduction studies, which neurology departments are set up to do. And so generally, we should try to have a low threshold for referring on to specialists who know more about peripheral neuropathy than we do necessarily in haematology clinics. Again, it might be one of those things that doesn't lend itself terribly well to being assessed in telephone conversations further down the line when people are phoning in during the pandemic. So be sure to flag it up so it can be looked into properly.
Yeah, that's some good advice there. Someone else also mentions that they experience frequent infections. Now, it's not a question, but it did make me think about how common long-term immunological challenges are and general problems with the immune system. Is that something that's common with chemotherapy, and therefore people being left with perhaps a lower immune system than they had prior to being unwell?
So I think there's a few layers to that question. So yeah, there are certain things which we definitely expect with intensive chemotherapy. As almost all of you will know, when you have a course of intensive chemotherapy, it wipes out white blood cell production. People are neutropenic, and there's a very, very significant risk of infection for the few weeks before the bone marrow steps in and the white cells return. I mean, the conventional wisdom in AML treatment when people are having intensive cyclical chemotherapy is once the immune system recovers, that, or the bone marrow recovers in the aftermath of the final cycle of chemotherapy, the immune system is largely intact again. But I think there is a bit more to it than that, and it certainly takes some period of time for some of the more subtle roles of the immune system to sort of reconfigure themselves. There are some chemotherapy drugs we use, particularly drugs like fludarabine, which have a longer term effect on some of the immune cells called the lymphocytes, which can go on for 18 months, 2 years, or sometimes longer after treatment. I think what's slightly different again is that the immune reconfiguration that happens after an allogeneic stem cell transplant is much more complex and can leave people in more long-term immunosuppressed situations. Even just having an uncomplicated allogeneic stem cell transplant, people are on additional immunosuppressive treatment for some time, period of months or longer afterwards. And if they get complications with graft versus host disease, which often require longer term immunosuppressive treatment, that can extend all of that into years. And sometimes that's a permanent feature if people are needing very long-term immunosuppressive treatment. As some of you will know, when people have an allogeneic stem cell transplant, it's almost like pressing reset, getting a new immune system, which then has to be re-educated and come across illnesses again, which you're going to be more prone to until the new immune system is kind of taken on its full repertoire again. And that extends to going through all childhood immunizations again in a regimented way over 2 or 3 years following the transplant. So after allogeneic stem cell transplant, definitely there are long-term immunological consequences to that, and particularly that's the case if people have chronic complications such as chronic graft versus host disease. Great,
thank you. And one last question for yourself before I bring our fellow panelists back in. There's an interesting question here about the survival rate for acute leukemia, and basically the person seems to be asking whether any of these long-term or late side effects have an impact on relapse, or whether they will essentially live, how long they will live for. Do the late effects have an impact on survival at all?
I think that the data on this are not as extensive as you might think. I mean, I think what we like to think is when people go through intensive chemotherapy and they recover from it and they're in remission, and we monitor them for a certain number of years, and we get to 5 years out from treatment, and we say that the leukemia is cured, that completely equates to going back to normal life expectancy. It's probably very close to that, but I think that there are certain long-term effects that people who've been through intensive chemotherapy are slightly more prone to than the non-chemotherapy exposed population, such as second cancers, which, although they may well be very treatable second cancers, if a person has a slightly increased risk of cancer compared to someone who hasn't been through intensive chemotherapy, that is bound to have some subtle effect on average life expectancy compared to someone who doesn't have that risk. I think, again, in the setting of transplant, where people have issues relating to the transplant that cause them to be immunosuppressed on a longer term scale, like chronic graft versus host disease, that will also inevitably, because of the risks of infection associated with that, have some knock-on impact on life expectancy as well. So it may be subtle, and it's certainly getting very close to the curve compared to what people are, the sort of life expectancy curve which people are on who don't have acute leukemia, but there are some subtle long-term effects on that. And so I think it would be disingenuous to say that it's completely back to normal, but certainly people who don't have to go through allogeneic stem cell transplant, who get a cure just through intensive chemotherapy, it's very close to being back on the normal curve again, I think.
Great, that's good to hear. The next question I wanted to address is sort of coming back to Kate. Somebody's pointed out or asked, do you have any advice for how to coordinate all these different people who are involved in your care? If you're affected by several different side effects. I wonder if you could comment, and then I'll come to Angie for advice from her perspective. But how do you cope with that, Kate?
Yeah, that's a good question, actually, because it feels like a part-time job or full-time job sometimes, trying to, coordinate what's going on and when. I think for me, and I know this might not be the right time to bring this into the conversation, but there's been a few questions I've seen come up and comments about kind of feeling abandoned after treatment finishes. And I think that's definitely a feeling I felt, not so much upset with my team or anything like that, but it's just like you feel like you've been cut adrift, like, okay, well, you're stable, and then I won't see you now for 3 months. And it's that 3-month gap, that a lot of people sort of mention. It's like, wow, that's so scary, not being in contact with anyone for 3 months. And then it gradually gets longer and longer, and now it's once a year, So I think that is quite a worrying time. And so trying to then keep appointments with various teams and people, and trying to work out who the best person is that you need to speak to for certain things can be even more scary, because you think, well, who do I speak to? I don't know, because your acute team that deal with you when you're in hospital, really you don't speak to them again or very often, and that can be traumatic because you get very close to them. I know I got extremely close to my treatment team, and they were just like became friends and family almost while you're going through it. And so that can be quite sad when you suddenly realize you're not going to see them very often. But I would say trying to keep up with who you need to contact is, I found that every letter I got or correspondence, I'd write down and I'd keep in a folder for various different departments. That helped. So then if I forgot, because I've got memory issues from the treatment and menopause, I would then go back and just go through and think, well, who did I speak to there? And try and get a contact, especially for the late side effects team. To have one contact or even just a department is really useful. And I know, especially at the moment, it's very hard to get hold of people, and that's totally understandable. But in normal circumstances, it's still quite difficult. So I would just say, yes, self-advocate and make sure that you kind of keep putting out the feelers and trying to reach people. Go to your GP as well and explain to them how you're getting on, and if you need any support, and if they would know how to get access that for you. But I think the main point of contact for me, and they were brilliant, was the CNSs in my department. I kept in contact with them, and they helped me to find support in other areas. They were brilliant. And also my consultant has been, exceptional, really. So yeah, I would say just try and keep a note of everything, write things down. It definitely helps.
You have to be very organised with these things.
Well, try to be. Yeah, it's very difficult, but try to be. Yeah.
Yeah. Angie, I'll come to you with the same question I posed to Kate, but also I wondered whether you wanted to comment afterwards on some of the isolation issues and what happens once you leave hospital as well, that Kate brought up there.
Can you hear me if I lean a little bit closer? Can you? Yeah. So I think the issues that Kate has brought up, is things that we may have struggled with, because, like Kate said, we're very close to our patients, and, we spend a lot of time as CNSs and obviously the doctors, they get used to having the same contact, and it is difficult to let go. And when, patients may be going across different sites and having different teams following their care, so joint clinics, so they might go to the one hospital regional centre on one occasion, and then obviously, and again, if you're having some side effects, you would get referral maybe to a neurology team, or like a dietitian, or a clinical psychologist, or someone that you needed to go to that expert for that advice. What I would say as well about people have become more isolated, but that's been exacerbated because of the current situation that we're in. But people's anxiety are heightened as well, and some of the calls that we've had is sometimes post treatment and later on after you've completed all the treatments, is that with the government advice and what should we do, because we might be we're in that vulnerable group. And I would say about utilise the charities and your local centres, and obviously your GP, because what we try to do is, once someone's finished treatment, they get treatment summaries sent to the GP, so that we try to highlight some of the areas that the GPs can help support our patients with. Because as Steve said, if they're followed up for 5 years, and then really we're trying to make that a little bit more seamless, that transition from one team to the community support again. But I would say utilise your charities, because there are support groups, there are buddies, and I think the buddies has been quite successful. And certainly I try to encourage any patients, whether that's in my NHS role or my Leukaemia Care nurse role, is that having someone on the end of that phone, and I found that with, yes, obviously acute leukemia patients, but some of our haematology patients generally, they do, I think, have been able to sit and have someone on the other end of the phone to actually just touch base. How did you feel about that? About, it might be diet, it might be exercise, it might be, you know, about how did they get on, about how did they feel about going to go for a walk, or be around other people more. And so I think, you know, try and tap into, because we can, as a charity, obviously we can put them in the right direction. We can try and get some help and support as much as we can.
Great advice, thank you, Angie. And wanted to take one of Angie's points back to Kate, I guess. Angie mentioned there the support of other patients in that period you talked about when you have less contact with your team. Is that something you found helpful at that point?
Yes. So I think just finding people that have been through similar or have the same sort of thing as you, same diagnosis, has helped. I think, like Angie said, contacting the charities, or at least trying to source some help from them, has been, you know, really good resource. I know Leukaemia Care at the moment offer a Counselling Fund as well, which is really worth looking into to help people pay for counselling. But I think, yeah, the online support, I found social media quite helpful. Things like Instagram, it helped me kind of contact or hear from people who had APL from around the world. That was great. And there are certain times when you don't want to be in that kind of situation. You know, it's too painful to hear other people's treatments, and you might be fearful of what the treatments you're going through could hold for you. So it's kind of, you've got to be mindful of how you're feeling, I think, and dip in and out of it, really. Access support when you feel you need to or want to. But yeah, I would definitely say search for things. Try not to go too far down the whole Dr. Google route, you know, and really, if you've got a really important pressing question, put it back onto your medical team, or ring Leukaemia Care and speak to people like Angie, you know, and ask the questions to them. But yeah, I think trying to find support from people who are going through similar is very helpful. Friends and family are great, but sometimes they don't quite understand everything you're experiencing, or, you know, it's difficult to talk to them. So yeah.
Sometimes that independent person is useful, aren't they? Yeah. Thank you for that, Kate. That's really, really helpful advice. As we're coming towards the end of our allocated time, we've got quite a few questions to get through. There's a question aimed at me and Steve there around a campaign to improve awareness of GP awareness among GPs of these long-term effects, and I'm pleased to say that it's something we do try and do a lot of at Leukaemia Care. We do GP educational courses online and in person when we're able to, and Steve has helped us with some of those. So I hope that reassures you, the person who asked that question, about what Leukaemia Care are trying to do in this area. A couple more questions around...
Sorry, should I just comment on that? I think it's really difficult for GPs, because sometimes people are coming... I mean, we become a kind of surrogate GP type service to a lot of patients who are seeing us several times a week sometimes, or over a long period of time. So quite often, and this might apply to some of you but not others, people just lose contact with their GPs completely. So I guess the biggest focus on GPs tends to be around the time of initial diagnosis, when people present with symptoms, and trying to alert GPs to what sort of things should really prompt investigations along the lines of looking for evidence of blood cancers. And I know that Leukaemia Care have been very active in that field, as Charlotte has said. But I guess the other time is this period, as follow-up is kind of becoming more spaced out and infrequent, or patients are almost sometimes being discharged from follow-up, where suddenly they land seeing a GP that they maybe haven't seen about any of these things for several years. So I totally agree that some education around that is probably is important as well.
Thanks for that, Steve. And my next question is also to you. We've had a few questions from Facebook about gastrointestinal issues long term, and I wondered whether you could say anything about how how common those are and what people should be doing to cope with those specifically, if possible?
Yeah, so I mean, in the short term, gastrointestinal issues are very, very common as people are going through intensive chemotherapy itself, as I'm sure a lot of you can testify to. It's very rare that people maintain a normal bowel habit all the way through course of intensive chemotherapy, but we probably don't need to discuss that in more detail. But in terms of chronic issues, I think a lot of this comes down again to post allogeneic stem cell transplant complications. We tend to see when patients have had intensive treatment, as with a lot of things, bowel issues do tend to settle and normalize over a few months following treatment. Again, that might be influenced, as we've said, with bony issues by any pre-existing bowel complaints or conditions that people have. But that, I mean, certainly in the context of allogeneic stem cell transplant and chronic graft versus host disease and being immunosuppressed longer term to treat those types of situation, we do see chronic gastrointestinal complications. I'm not personally as experienced with that because I don't tend to be involved in the specific long-term monitoring of allogeneic transplant recipients. So other than to say it's really important that those symptoms are flagged up and discussed in your post-transplant appointments, I'm not going to say too much more beyond that.
No, thank you for that, Stephen. Appreciate that. And it's come up a couple of times as we've been chatting, but it's not something we've covered in any detail. I'll start with you, Steve, since we're sort of already in conversation here. Cognitive issues and fatigue, is that something you hear a lot of as a long-term issue that from the patients you see?
Yeah, relatively common. I mean, fatigue is very, very common at all stages as people are going through treatment and following completion of treatment. And it's something I don't think we're very good at dealing with as medics. Sometimes there is a readily correctable factor, which is the hemoglobin level, and we know that anemia associated with leukemia and chemotherapy treatment contributes significantly to fatigue. So particularly while people are going through treatment, we tend to support with red cell transfusions. That's much less the case following completion of treatment, although people, again, particularly following transplant, can often have suppressed blood counts for various reasons, for treatment of infection or immunosuppressive treatment. So sometimes there is a clearly treatable medical reason for it, but there's no doubt that chronic fatigue is very common following completion of AML treatment, be it with intensive treatment or with transplant. I think it's something, again, it's one of these things that medics are probably not very good at advising on by and large, and I think some of it comes into establishing physical activities and trying to get back into pre-diagnosis routines, balanced diet, moderate but not sort of moderating and alcohol intake, those sorts of things, and also I guess trying to be reassured that it's normal and you shouldn't expect finishing intensive treatment to be like flicking a switch and getting straight back to normal. And it's a tremendously personal experience and it's very variable between different individuals. I mean, we tend to sometimes give a sort of general guide that 6 to 12 months following completion of intensive treatment is a sort of ballpark estimate of how long it takes to gradually get some sort of normality back. But it is so tremendously variable that I don't think people should be too harsh on themselves, and they shouldn't be expecting just to jump straight back into activities and feeling any sense of sort of personal failure that they're not able to do that, because it does take a long time in many cases.
Yeah, definitely. Kate, is fatigue and that similar issue something that you've got experience of? Is it something you're still experiencing as someone who's a few years out of active treatment now?
Yes, I'd say definitely during treatment. I mean, you're just wiped out a lot of the time. Obviously, if you're in hospital, then yeah, that you're seriously kind of poorly and having to go through intensive treatment. But even as an outpatient, sometimes, I mean, I had arsenic treatment, the majority of it as an outpatient, and that in itself was exhausting. You'd spend 8-9 hours a day in hospital, you know, sat waiting for treatment or having the treatment, and then having to have various other things, you know, potassium infusions and all sorts whilst you're there. So that is exhausting. But I think long term, yes, I think Steve's completely right that give yourself at least a year post, you know, intensive treatment. And maybe even longer. You know, everybody's different and everyone's had different forms of treatment, and quite often, as I found, it's you have lots of treatment in a very short space of time, and your body obviously is going to struggle to get back to some sort of you know, normality, whatever that is. Yes, I feel I am back somewhere near normal, but I don't think I'll ever be back to the level of fitness that I was before I was diagnosed. But I think that's difficult to deal with initially, and even now really. But I think, like Steve touched on, I think just be kind to yourself and sit back. Sometimes you can be very harsh, you know, and sort of think, why can't I do this? Why can't I be like everyone else around me, or my friends or peers or whatever? But I think it's like, sit back and think, yeah, you've been through a hell of a lot. And for some people, they're still going through it. They're having ongoing treatment. And it's just being a little bit kinder and gentler to yourself and thinking, okay, well, let me see how I can help myself. And I definitely found, for me, you know, getting back to eating healthily again and trying to nourish my body that way. And also doing gentle exercise, even just walking, Pilates, yoga, all those sort of gentle kind of exercises helped, just to kind of feel my body working again. Yeah, but it is an issue, definitely, fatigue.
Angie, just picking up on something Kate said there about, you know, diet and exercise and all those sorts of things. Is there things people can do to minimize these long-term side effects, or is it a case of just keeping yourself as healthy as possible to help you cope with them, do you think?
I think there are more information out there now about how to deal with fatigue. So we do, as you know, put some study days on when we're able to, and we've got literature that can support that. So sometimes there's like practical things. So sometimes if we get a phone call from a patient or a family member, how can we support them because they're so tired? Then there's things that we can maybe think about adapting your day. If obviously you're able to go back to work, and then talking to your employer so that, you know, you can't expect to go back to somewhere full time. It might be that there's, you know, that they can put adjustments in the working environment. And there are a lot of places as well, and you know, we are lucky locally, but sometimes you can get referral to like an exercise rehabilitation program where they've got like almost like trainers that will take you through that slow and set up a program for you. Or there's more online now, you know. I know we touch on the pandemic, but I think the pandemic has highlighted very much about isolation, fatigue, you know, online, trying to keep the country exercising, you know, like Kate said, and going for a walk. It actually lifts our physical well-being. It makes us feel better emotionally and physically, and sort of, yes, having that contact with individuals or your neighbours. And at the moment we can't do that, but sort of almost getting back into that community again, isn't it? Is sort of almost getting used to getting back to some sort of a life of what we had before. But it takes a lot of time. We can't just, as Steve said, flip the switch and you're going to go back full time. It's a gradual process, but it's very much an individual process. And I think people have to be guided as to what's best for that person. And it's going to be very different for each individual.
Yeah. Always worth encouraging everybody to be kind to themselves as well as to others. Penultimate question then, and this one's for you, Steve. We've talked a lot about various physical side effects that can come with treatment. What is there a difference between a long-term side effect that manifests itself during treatment and continues, and a late side effect that doesn't appear during treatment but may appear sometime after finishing? I hope that makes sense.
Yeah, I was trying to think about the answer to this question. I think it's just semantics, really. I think probably I would interpret it being a long-term side effect as being something that probably starts when you're actually going through your treatment, and then persists for some time after completing the treatment, whereas a late effect is something that genuinely isn't actually present while you're going through the treatment, but is a sort of recognized thing that can occur further down the line. So I guess an example of a late effect would be something like in the setting of allogeneic stem cell transplant and body irradiation, sometimes people develop cataracts as a fairly predictable late effect of total body irradiation. So it's something that just needs to be asked about. So when it happens, people can be referred, and this is often much younger people than that would be developing age-related cataracts that can be picked up, and appropriate things can be done about it. So I don't think it's probably not all that helpful thinking about long-term side effects and late effects as separately, because they're all things that should be picked up through however late effects are monitored. So we've already touched on the fact it's very different in different parts of the country and different follow-up settings. So I mean, in Cardiff, for instance, we would have the bone marrow transplant team would be seeing patients in their kind of late long-term follow-up clinic or late effect clinic at 6 monthly or 12 monthly intervals, and then in between we would be seeing them in more regular general haematology clinic follow-up. So they're both things that should be monitored through those sorts of setups, but I think it is semantics.
Sorry, I forgot to unmute myself then. It was bound to happen at some point. Yeah, I agree, it is largely semantics, and hopefully everybody should get support with every side effect they experience. So I wanted the last question to be to Kate, and we've touched on it at various points throughout this whole discussion. I've seen a few comments about the psychological impact of blood cancer, and obviously it's a very personal thing, but I just wondered if you could end by maybe giving like a few tips on coping with that long-lasting psychological impact, things like fear of relapse and isolation and things. You want to say a few words about that before we wrap up?
Yeah, sure. So I think fear of relapse is definitely something that is always in the back of my mind. You know, I have relapsed once, and so you kind of think, would it happen again? It's almost a waiting game, really. I would say just you're aware of your body, you know the symptoms because you've been through it before. Try not to panic, but if you do think you are suffering from symptoms again, definitely reach out to your team or a GP and just make sure that you get them checked. Regular blood tests, if you're still offered them, take them, and try to live your life. And I would say be aware that it's different. You know, you can't go back to the life that you had pre-diagnosis in all aspects. A lot of it, yes, you can, but not everything. You know, you've been through something very traumatic and difficult, and everyone has different ways of coping with that. But for me, I found it was just recognizing that and accepting that, yes, you have changed as a person, but maybe not always for the worse. You know, some things have changed that I think have made me a better person. I definitely am more attuned to life and living, you know, in the moment, so to speak. And it's just making the most of those moments when you feel like, okay, I'm still here, I'm still going. What can I do with this, you know, and moving forward with that. And you can't always live in that emotion or that feeling because it's fleeting a lot of the time. But for me, I think just embracing those moments and thinking, okay, come on, you can still keep going. You've been through so much already. So yeah, just keep on going, basically. And ask for support, because although we talk about a lot of various avenues of support, very rarely is it given to you or offered to you. You have to go out and seek it. And that's difficult because a lot of the time you're tired, or you're going through treatment, or you're feeling poorly. But I think just trying to look for it and know that there is support out there in many ways. Just self-advocate and be kind and gentle on yourself, and look for the support as and when you feel you want and need to. Reach out to people, talk about it if you want to. I found writing helps, writing things down, you know, even if it's just in a diary or whatever you want to do, that helps just to kind of process things. And know that some days you're going to have down days, you're going to have bad days, and you're going to feel rotten, and just let them be, you know, have those days and know that there's better days around the corner. And to just be, you know, grateful that you're still here and that you've been through something really traumatic, but good on you, you did it. So yeah, I'd say that.
Great, thank you, Kate. Some really lovely messages there, and a few people saying that they totally echo what you're saying. So that's really good to hear there. Okay, so it's been a wonderful discussion, and I think we've covered a crazy amount of topics, some of which I'm sure we could do a webinar all on their own about. But thank you guys for helping me answer some of the questions we've had today. I just wanted to finish up the webinar before we say goodbye with a few bits of info about other things we've got here at Leukaemia Care. So as you see on the slide, we've got a number of sort of information sources. And this includes information on COVID-19. I know a lot of people have got questions on that recently. Our next webinar is on COVID-19 vaccines, which many of you will find interesting. So please get in touch if you want more information about that. That's on Friday afternoon. Could I have the next slide, please? Thank you. Could we go back one? Oh no, sorry, apologies, go back. Next slide, thank you. I just wanted to point out specifically from the information sources, a couple of booklets that are relevant to the topic we've discussed today. So we've got specific booklets on living well with, which give advice on sort of diet and exercise and the sort of things that Angie and Kate were talking about, emotional impact. And we also got a couple of booklets about late effects and common side effects that cover a lot of the physical issues that we've discussed today and more. So please do look on our website for those, or we can post them out to you if need be. Next slide, please. And then, of course, we've got all our support services. So if you do need to talk to somebody, either a patient or a member of our team, about anything we've discussed today, or indeed about anything else, please do get in touch. With multiple ways of doing so. And the Counselling Fund is that Kate mentioned earlier is open for applications if you do, if you would like some support in financial support in getting some counselling. Final slide, please. Thank you. And I just wanted to end by a little advert for today's virtual support group for AML. It is aimed at the south of the UK. Obviously, there are arguments as to where that line of north-south is, but it is open to everyone because it's being held virtually at the moment. So if you did want to chat to other AML patients, you need to register by 2:30 today, as the next meeting is at 6 o'clock. And then if this particular one doesn't apply to you, if you're not an AML patient, we do have loads of other support groups on our website. So if you follow from our website homepage, the instructions at the bottom of the presentation slide there, you'll reach all the support groups we've got and a list of the dates. I think. Oh, and well, let's leave that up while I finish up. That's our contact details if you do want any more information on anything. I think all that remains to say is thank you to our panelists for a great discussion first thing in the morning. I certainly feel more energized for it. Thank you, Kate, for your personal perspectives as well. I know sometimes it can be difficult to share that, and thank you, Steve and Angie, for your time. I'm sure you're very, very busy in the NHS at the moment. Thank you everyone for watching, and we'll see you at the next webinar. Have a good afternoon. Bye everyone.